You're listening to The Dental Guys, episode 107, The Dental Guys Book Club, Part 4, Zero Bone Loss Concepts by Tomas Linkovics. This week we continue by reviewing chapters 9 and chapters 10 and complete the surgical portion of Zero Bone Loss Concepts. We discussed, does horizontal connective tissue around your implants really matter? What dimensions should you consider? And what about your implant choice? Tomas makes some recommendations in Chapter 10 that you're going to want to hear. We even discuss a little bit about third wave coffee this week on The Dental Guys. Looking for a lab that understands the bridge between art and science? Check out the Dental Crafters Network. Dental Crafters, one relationship, infinite possibilities. Contact them at 1-800-472-8302 or at dentalcrafters.net.
Do you want to learn to predictably place and restore dental implants using the most modern science and technology? We are talking 60 hours of CE and a comprehensive curriculum and live surgical implant placement on pre-selected patients. Head over to restorative-driven-implants.com to learn more today. Well, hello and welcome to this week's episode of The Dental Guys. I'm John, the Dental Guy.
And I'm Wes, the Dental Guy.
And for us, it's the first episode of 2020 that we're recording, so it's going to be released here in a little bit. But, it gets a little crazy around Christmas, and we've been kind of preparing for what's coming up. But it's good to finally get to sit down and record after kind of like we're trying to recover from being out for a little while from the office, and then, you come back. And like
vacation coma.
That's and that huge stack of like bills and mail gets like boom dumped down on the desk, and it's just demoralizing. You're like, I gotta like dig out of this. And of course, if you've been doing any kind of like tax planning, you're trying to typically delay income into 2020 or the next year, and you're trying to buy a bunch of crap a lot of times to, maximize expenses in the year. So, then you get all these bills. You're like, great, just bought a bunch of stuff, bought like my first 2 months worth of supplies. And now all these bills come in. I'm like, ugh. So anyway, it just is what it is, man. It's part of it. And then you're trying to like dig. I had like 4 emergency calls over the break, including a marathon runner. Say this is reminiscent of my story I told about when I fell running in Dallas. Oh, no. A marathon runner patient, he was 20 miles in and tripped and fell and fractured number 9 and 10. 10 was mobile. 9 is a horizontal root fracture, about 2/3 of the way down the root. We're hoping is savable. But anyway, I get a call. Yeah, he fell and fractured his teeth, and, it's ugh. So anyway, it's just been the way it is. But thankfully, things like a good cup of coffee bring it back, right? And we haven't really talked about this on the show very much, but both of us we talked about it a little bit back with Darren Deester back in the day, right? We had like a little brief conversation, geeking out.
That was a live
That's right.
video.
That was right. It was out at Spear, but both of us are sort of into the whole coffee thing. Third
craft coffee.
The third wave coffee.
That's the new way of saying.
Wes, explain third wave coffee to our listeners, because it's so easy. I just want to first of all say there's a thing, if you guys have watched, there's a show out there. I'm just going to say I don't usually use these words a whole lot on the show, but it's called the douchebag jar. And let me just define the douchebag jar, okay, for those of you guys who don't know what that means. It's basically the idea is that if you say something that makes you sound like a snob, okay,
right,
then you're supposed to put $1 in the show. This comes from the show New Girl, which my wife loves. She loves Zooey Deschanel. Anyway, and it's a running gag. Essentially, it's one of the guys is always saying something that makes him just look like a total snob, and he has to put. So anyway, everything we're about to say, we realize is like put $1 in the douchebag jar. So we accept that. We are those people. You guys probably already know that. So Wes, what is third wave coffee?
Well, third wave coffee is really just a term surrounding people that enjoy high quality coffee. And if you've ever listened to this show, you've missed it. I mean, I drink coffee on this show sometimes, and so does John. I think, hey, John, you have a cup of something
got a cup of some
right there
methodical
right
right here, yeah.
And I just had a cup. I just had a cup of coffee that was amazing, and that's how this coffee conversation started. Was John made a trip to one of his kind of premier roasters of 2019 that he kind of just lucked into finding.
Yep.
Methodical Coffee.
Yep. Greenville, South Carolina.
Greenville, South Carolina. You got to check them out online.
Yep.
They've got some good roasts going on down there. And one of the things that Third Wave Coffee brings about is you're really intense about finding high quality coffee, and I've really tried to find it locally. Luckily, I live in a town where I have several Third Wave coffee shops, which basically means they roast and they brew coffee in the same place.
And,
so
and
you
Third
can go
Wave,
there.
I mean, is essentially saying that it's kind of looking at coffee like, I would say, looking like
wine.
Like wine. It's very similar.
Yeah.
It's like, where it was grown. You kind of understand how like the soil, the weather affects the beans, and how the different roasts affect the flavor, and you choose the beans that are freshly ground and freshly roasted within a certain amount of time. You measure out the water, you measure out everything is calculated. Yeah. Everything to enjoy coffee to basically the highest level, right?
Let's talk about a particular website that John just turned me on to called Coffee Compass, thecoffeecompass.com. And the New Year's resolutions that they put up for 5 coffee resolutions for 2020. And I like them.
Yeah.
I like them. If you want to check it out, thecoffeecompass.com. I'm just going to hit a few of them right here. And one that I really like, because I try to do these things, is stop under extracting coffee.
I love this. Now,
here's the thing.
This is where you have to put $1 in the douchebag jar for saying that.
Seriously, right?
Stop under extracting.
So, the only way to do this is if you have a grinder, right?
Yep.
And so let's say you're down to the bottom of the bag, right? I don't want to waste any beans because I want to be, actually one of these resolutions.
Yeah.
Is don't waste any beans. So say I end up with 20 grams left. Yeah, I weigh my coffee. Okay. I'm going to actually make my grind a little finer with that 20 grams so that I can over extract, right? I've got more water in contact with the grind, with the coffee bean, okay, powder, okay?
Love it.
And one of the things that is kind of becoming more, kosher to find in one of these Third Wave shops to make sure that you're extracting the coffee is a refractometer. Okay, now I don't have
refractometer. Man.
Right, because you're measuring the amount of coffee in the water dissolved in solution. And so what we're looking for, right, is around 20%. Okay, and so it's a $300 machine here. It's a chemistry set. To do this. So pretty cool stuff. Check out thecoffeecompass.com.
Wait, when you start getting into this world, it's like a slippery slope, because the first
I don't want to go.
The first thing you need to do, because for our listeners, okay, I know you're probably going, oh man, these people. But if you've listened to our show long enough, you knew something like this was coming. I mean, Wes, and I always talk about stuff like this. But if you want here's what you should do, because Starbucks is not Third Wave coffee, really. Not the typical Starbucks. I mean, it's not bad. We're not saying it's bad, but we're saying, that was where people started maybe first getting turned on to making like a consistently more quality, focusing more on the quality of the coffee versus just gas station, whatever's there. But what you should do, if you haven't, is seek out a shop that does this. Now, I would say probably, I think you'd agree with me, Wes, that if your average person, if you're near any type of big city, you should go check out a Blue Bottle Coffee, right? Go check out a Blue Bottle coffee shop for a good example of a a very consistent, high quality third wave coffee shop. And the reason we say Blue Bottle is because there's a ton of them. Now, we'd prefer you find a local place that's is nearby to you, so you support your local economy. But if you go to like New York, or you go to San Francisco, or you go to some place that's got some civilization, that you're gonna find Blue Bottle, and you can experience what we mean. Ask the barista about the coffee, ask them about the beans, ask them where they came from, and they're going to know things. Just like if you went to Napa and asked about the wine that you're tasting, they're going to know the history, they're going to know the weather in the area where those grapes were raised. And if you start learning how that affects it, and you leave yourself open to the idea that you can experience these different tastes and smells and aromas and things, it can be very cool, because it doesn't take a lot of gear or a lot of knowledge to make a really great cup of third wave coffee in your home. And it really changes the game of your day, spending a few extra minutes, because it takes a few extra minutes.
Yeah, I mean, I spent 5 minutes just making a single cup of coffee just a minute ago.
Yeah.
But I actually really enjoyed it. I enjoyed making it, but then I also enjoyed drinking it, because when I was tasting it, and as I was tasting, I was like, do I get some notes of like lemon and like some lime in there? And I was like, it's kind of finishing with a more lime. And I go over and get the bag, and that's what they had written on the bag.
Yeah.
And
so you've been around,
and that's
long
what we're
enough
talking
to
about.
know.
That's what we're talking about, is that this is kind of a specialty type of a thing, but I really feel like that it's not going away.
No.
And it's something that you're going to see more and more of, these off the beaten path roasters. You're going to see companies that you thought you'd never heard of come to the front, like Methodical. We used to say that Blue Bottle was the echelon of all like third wave places, and then they've recently been bought out in the last couple of years by Nestle. So we're not saying it's a bad thing that Nestle bought them. I'm concerned about that, right? But
that tells you a lot about how this is getting bigger, is that even big companies are seeing this kind of like microbrews, kind of like, again, winemakers. They're looking at this and going, okay, craft brewing, craft coffee, it's very similar, and it's very cool. It's very cool.
It's very cool. It's cool to be able to go down the road from my office and visit a guy that's doing it right, that is investing in high quality roasting equipment, and he kind of brings me back and shows me what he's doing. That's fun, right? Because he's developing taste by the roast, and then I'm helping to extract some of those things at home of what he's trying to intend the end drinker to get. Yeah. So that's cool.
It's pretty cool. Right? It's pretty cool. So anyway, now we're gonna just leave you with that. Go check it out. You should go, learn more about it. If it's something if you like coffee, if you already like coffee, you should definitely take that up a notch and find a great craft coffee place, or maybe even try it in your house. And this episode is a continuation of what we've been doing, going through Zero Bone Loss Concepts by Tomas Linkevicius. And one thing that's been really cool is to see him kind of reposting what we're talking about.
We appreciate that.
And we really appreciate that, because I think it kind of validates that, first of all, we're kind of getting across what he intended, and it's giving people another way to connect with what he has written, and hopefully what's changing your practice. And today we're going to get into more of these surgical concepts, or essentially things dealing with more of the surgical or biologic side of what creates an environment that is conducive to zero bone loss. Last time where we left off was with vertical soft tissue thickness, which is such a huge part of really what brought a lot of his book into being, or his research was really focused on this. But this next chapter, chapter 9, it's a little bit more challenging, I think, because the vertical soft tissue thing makes sense because we understand biologic width. So I think it's just another step in our minds forward. It's a game changer, but it kind of makes sense innately. But when you start talking about this next chapter, which is attached tissues around implants, I think at first glance, everybody's like, oh yeah, well, of course you need attached tissues around implants. But is that really true? What is attached tissue? What does that mean? So we're going to get into that, and we're going to talk about what is important about that. So Wes, why don't you? I kind of let you take the lead on that because I know you've been kind of focusing on this chapter.
Yeah. So after we get back from a word from our sponsor,
that's right.
We're going to get right into chapter 9. We're going to finish out the surgical portion, and we'll see you back right after this word from our sponsor.
Hey guys, it's Justin Goodbread here with FinanciallySimple.com. So at this point, we're working on increasing the value of our company and we're focusing on planning. So many dentists are efficient in managing your calendars for work. However, managing the planning schedule is often lacking. Here is the planning schedule that our top dental clients utilize. At the beginning of the year, we outline the top 3 objectives your practice must accomplish during the course of the year. Now, like we talked about in the last episode, you would condense your objectives down to 4 90-day blocks. Then you break the action steps down to monthly pieces, then to weekly, and finally to daily. Ever heard the old adage, how do you eat an elephant? Yeah, well, it's done one bite at a time. Focus on making small, accomplishable daily and weekly action steps that drive your practice toward your yearly goal. If you've never dealt with strategic planning, then you need to take a look at our course on FinanciallySimple.com. If you have any questions about how to drive the value of your practice up or how to potentially double your net worth every 3 to 5 years, hey, reach out to us as well through FinanciallySimple.com and we'll be more than happy to help you. For more information about today's topic and other dental related topics, head over to FinanciallySimple.com/dentist. Until next time, make it a great day.
All right, chapter 9. We're going to finish out the surgical portion of this book, the first half of this book, chapters 1 through 10. If you've been listening, we just finished up chapter 8, as John was saying, vertical soft tissue thickness. Now we're going to talk about attached tissues around dental implants. Now, John, you and I had a conversation probably about 3 or 4 years ago on a plane about how I was kind of becoming anal about some of the things I was seeing with in regards to mobile tissue, okay, around my dental implants, especially since I had moved to a more crown and bridge, let's say, style dental implant restoration. And we're talking about good emergence profile, matching the contours of the adjacent teeth. And whenever you take out teeth, you're going to lose the buccal plate to some extent because of the muscles that are pushing in on those things. And what happens is that naturally you see the mucogingival junction migrate up the ridge or across the ridge or closer to the center line of where the tooth was positioned. And so that means you narrow the amount of attached tissue. And I mentioned to John, I said, John, sometimes when you see the rolled mobile tissue, like you can take the periodontal probe and lay it horizontally across the free gingiva and move it up and down. I said, how sometimes you see that against your restoration? I said, that kind of concerns me a little bit. And I said, one of the things that I'm really trying to look at is, can I maximize the amount of attached tissue to the buccal? And that was just the conversation we had on the plane. And I was describing some of the things I was doing at uncovering to maximize, like apically repositioning flaps using what I call maybe a jelly roll technique, where I'm moving connective tissue from the palatal aspect or the lingual aspect and cheating that to the buccal, repositioning that on my healing abutment so that I have a dense, bound down fibrous tissue around the dental implant restoration. Because to be honest with you, implants are not protective. And one of the things that Tomas says right here at the beginning of chapter 9 is he says, when an implant is placed and restored, soft tissues should ideally adhere to the prosthetic components and prevent the inflow of bacteria and plaque into the peri-implant sulcus, protecting the integrated implant. Now, we know that that's very difficult to achieve. Some people are trying to achieve adherence, but what we know is that a dense, bound down, non-mobile tissue. And let's define that.
Yeah.
That's what we're hearing being called what, John?
Yeah, functional connective tissue.
Functional tissue.
Yeah,
and that's
something that's really challenged us. And I think that's why this chapter is more challenging, because I think he's saying again is you don't necessarily know if 1 millimeter of attached tissue is not enough. In some situations, it might be enough. He's going to talk about later in the book that even the restorative material may matter. In other words, if you have certain restorative materials that are maybe more porous, attract more plaque, that maybe you need more attached tissue potentially, or if you have, say, a material that's very smooth, doesn't attract plaque, maybe it's not as big of a deal if you have less attached tissue. But for the sake of discussion here, let's talk about this, Wes. Like, we went out to Pat Allen's course.
Yeah, just go right. You read my mind.
Yeah, and this is where, so I had read this book probably a month before we went out to Allen's course on connective tissue grafting. And really this book and Link of Vicious kind of inspired us initially to go, okay, we need to go learn about soft tissue grafting because we understand the importance of this soft tissue thickness. And Allen's whole thing was, he's like, I want to make sure that everybody knows that we understand what attached tissue is very differently than maybe what we used to. The idea used to be that it was keratinized tissue that was what we were looking at. So we would say we need this amount, quote unquote, keratinized tissue. And what histology has shown is that when you do connective tissue grafting or allograft, with alloderm, you do the histology and you find that even if the tissue on the surface is not keratinized, on the histology, this tissue is attached to bone. It's still attached tissue. But even so the words become kind of difficult because if you say attached, how you can't eyeball that necessarily, Wes.
Well, let me just say this, is he said that keratinized tissue is not even in our textbooks.
Yeah.
As far as from a periodontist standpoint. And here I have sitting beside me. It was great, John, because we didn't sit beside each other.
Yep.
Yes, we sat on the front row.
Of course.
If you know the dental guys, we always sit on the front row. You'll find us there. If you look for us at meetings, we'll be on the front row. But John sat beside a periodontist, practiced in 25 years, your guy? The guy beside me who had been practicing 40 years. As he's talking, Pat Allen's talking, both of the periodontists that are sitting beside us are shaking their head. Yeah, keratinized tissue really is not what it's about. Mm-hmm. It's about thick, fibrous, bound down tissue.
Right.
Now, does the keratin matter? Does it matter? According to Pat Allen, it doesn't.
Right. He's saying that it's not about the way that it looks. It's about what is it actually doing histologically. And so when you read this chapter about this 2 millimeters of attached tissue, we need to make sure that we're careful to not just define that as keratinized tissue because if you've done grafting, if you've augmented that, it's much more important that the tissue is functional tissue. It's functionally attached tissue. So I think as we're talking about this, that's why when we start reading through this chapter and Link of Vicious starts talking about how to increase the amount of attached tissue around implants, he talks about several ways to do that, some of which Wes already kind of mentioned, apically repositioning flaps. He talks about doing augmentation. And we don't need to dive
gingival grafting.
Yeah, and we don't need to necessarily dive into the high weeds on this because everybody kind of knows, I think, what most of the ways are to increase the amount of attached tissue around things. But I think that the other thing I want to focus on a little bit, Wes, is, he says in this chapter at one point, he says, we know that vertical soft tissue thickness is important, and we know that having attached tissue is important. So even if you have one, but you don't have the other, you may still have a risk of more bone loss. And so I think that's important to focus on, is that we should be making sure we have both things.
Yeah, he goes on to define exactly that one recommendation is to have at least from buccal to lingual or palatal to buccal, you need to have a minimum of 4 millimeters. Now that's if you're going to do a crest of the ridge incision. You want to split the difference. If you take our surgical principles course as a part of the restorative driven implants segment, they'll talk about, splitting that or doing techniques to apically reposition to create a zone of attached tissue that gives us this 4 millimeters. And I think that that's a starting point for us to start having a discussion. And I think that's what Tomas is saying here, is that there's not hard evidence right now, right? But from the evidence that we can see, that having 2 millimeters of dense, bound down tissue, I like saying it like that, functional tissue. I think we're going to hear more about this in 2020, is that it's going to be protective and be one of the factors that creates zero bone loss around our dental implants. Now, here's an interesting thing, John. You can't take a traditional bite wing and see the results of this.
Yes.
You can't even take a CT, because a CT will blow right through the buccal plate.
Yep.
Right? Because that there is you just can't, unless you have, other types of imaging, or unless you lay a flap. And who's going to do that?
Yep.
Right?
Yep.
And those types of studies are hard to come by. But I think what we're saying here is, and what Tomas is saying, it just makes sense for the protection of the implant complex. Okay? And when I say implant complex, I'm talking about crown, abutment, and implant. Because if there is thread exposure at the base of your sulcus on the buccal, that could be enough thread exposure to create a bacterial infiltration into the rough surface implant that you have placed and create bone loss.
Yep.
That's what he's saying.
Right.
We need protection.
And I think, again,
thick,
as
bound down tissue, functional tissue.
Right. And I think that down the road in this book, again, as we get into those later chapters, we're going to talk about how that protection may, again, become more important if you're talking about materials that are more apt to attract plaque. And it makes sense. If you have more bugs hanging around, you need to have more protection from into that very weak connection in the epithelial layer, that hemidesmosomal attachment that is not strong. We may need to have thicker and more attached tissue. So I think that it's the thing that's messing with us a little bit is just understanding what the definition of attached tissue is, that you cannot look at it and tell. So make sure that as you're just as much in the last chapters, we talked about augmentation for vertical reasons to get thickness. We also need to be thinking sometimes more about either augmentation or repositioning flaps in order to achieve adequate attached tissue. Don't let that be the thing that takes your implant down, because you were so focused on the vertical aspect but not focused on the attached tissue aspect. And this really comes back. Here's where it hits home the most for me, Wes. Punching when implants are placed, right? Versus flapping. And
hey, let me just say this. The sidebar conversation is that, do you ever see him talking about punching?
I don't see that.
It's interesting, the evolution that we've seen in dental implant surgery. Yes, punching has been proven to work.
Sure.
Okay.
Sure,
we
it can
know
work.
that the success rate of dental implants, but surgically, when you start to apply the principles of good incision design,
Yep.
this right here, this chapter is totally against punching.
Yep. Because
Right.
think about this, listeners. If you think about, okay, you're looking at, and I know not all of your implant placers, it doesn't matter. If you're the
Yeah, it doesn't matter.
restorative doctor here, you need to understand what your surgeon is doing, because you need to understand what your restoration is going to be based on. And if you have, so imagine the scenario. You're looking down at the mandibular ridge in the 18, 19, 20 region, and those teeth have been gone for a long time. That buccal plate is resorbed. We know that mucogingival junction tends to migrate toward the area over where you would place the implant to get it in the prosthetic location that you would like, because you've lost bone. So when the surgeon places the implant, if they get a surgical guide which just has a hole in it for the ideal prosthetic location for that, and they use a tissue punch and they just go right through that and punch out all that tissue, there's a good chance that the buccal half of their implant, or maybe the whole implant, is going to be in non-attached tissue. And so what needs to happen is we need to think like doctors instead of just being a robot here that's just not even thinking and punching tissue. And we need to design that incision more toward the lingual so that we are in attached tissue. And then that attached tissue needs to be potentially repositioned apically toward the buccal side, sutured down, so that the implant has attached tissue on both sides. So just imagine that scenario. And I think a lot of people who are punching or doing flapless implant placement, if you hear that term, flapless, same kind of thing for restorative dentists, maybe don't understand what tissue punching is. Another term a lot of times you hear is flapless implant placement. I think it's rarely indicated, Wes.
Yeah,
rarely.
we've moved away from it. A couple years ago, before we had started RDI, we discussed this amongst the couple people that I was with, and I really just tried to move people away from punching altogether.
Yeah, and we're saying this in the healed ridge. Let me specify that.
Yes,
when you're doing immediate implant placement, sure, we don't need to lay a flap. You're in a socket. But when it's a healed ridge, is what I just want to make sure people don't get confused, thinking, oh wait, you're saying that anytime you take a tooth out, you could flap. No, you shouldn't be flapping when you're placing immediate implants. If you can avoid it at all costs, avoid it. But healed ridge is what we're talking about. And I think that this chapter makes it pretty clear that you need to just be thinking more about where your implant's going. And if you see that the tissue is not where it needs to be, figure out a way to get it there. And if you don't know how to get it there, go take some courses or refer to somebody who does. And be careful, because this, I think, is a lot of general dentists, for instance, in the U.S. are getting involved in implant placement. Wes, this is one of the number one problems that I think we're seeing that's leading to problems with implants is people not thinking about where the tissue is and placing implants into this mucosa or this unattached tissue that really does not protect the implant. And if you're using the wrong kind of implant or not placing it subcrestal, if it's a rough surface implant, that's a recipe potentially for disaster of being in mucosal tissue and having this rough surface exposed and plaques adhering to it. And you might have got a great prosthetic result, but your biologic result is not going to be good.
I'll tell you what, this is, not to digress here and start talking about a lot of different things, but this is where implant dentistry is one of the most complex subjects that we handle in our office, right? From a standpoint of there are so many things that can make or break you. And we've said this in the past, and we got lucky. I'm just going to say that, right? John and I got lucky. And because we were applying some principles early on in our career, and we just lucked out.
Yep, on the protocols we were using.
Yeah, on the protocols we were using. And what I'm going to say is that it's not going to be at 1 year you're going to see the results of good or bad surgery.
Yep.
It's not going to be at even 2 years. But at 5 to 10 years in practice, and you might say, you know what, I'm going to be gone by then or moved out of that town.
Right.
Well, that's the best way to track your success is to move away from it.
And then everything's always great. Yeah.
And then everything is great because you're not dealing with the problems. But, whenever I got serious about placing dental implants, I started thinking about how long this patient is going to have this restoration.
Yep.
And how long they're going to have this dental implant. And each one of these things starts to add up to more and more success.
Right.
And we've learned so much from this book. And I think it's good to kind of sum up this surgical portion of this book with chapter 10.
Yeah, chapter 10 is really
practical.
Yeah, it's really taking all of that we've talked about up until now and talking about, okay, so we got all this science, right? And of course, we love the science. We know some of you guys listening to this are just like, give me the bottom line. Well, this is the bottom line really about what does all of this mean? How do you apply
This could actually, John, this could affect you in a big way because you could have invested in a particular style of dental implant.
Yep. And you might need to change.
And you're gonna need to change.
Yeah. Yeah. And I think that he's saying pretty clearly in this chapter that there's different. One of the things I love about this book is it is implant agnostic. In other words, it does not focus on just one implant. It talks about how you can use multiple designs as long as you use them appropriately. And we've covered that in previous episodes about some of the things you need to watch out for. But he makes it pretty clear here at the beginning of chapter 10. He says the author's current recommended implant is, right? So everybody's been waiting to hear this if you haven't read the book. Author's current recommended implant is a bone level implant with platform switching and a conical connection. Now,
Oh, man.
that is a pretty strong statement because there's a lot of people out there who don't want to actually say, this is what you should be using. Because he's careful. He's careful to say right after that, of course, this does not mean other types of implants should not be used, but rather that this implant can be used in the majority of clinical situations.
In fact, 90% of the time, if you look at page 128, he describes this particular implant and how it can be used in 90% of the clinical cases that you're going to see in private practice.
Yeah, yeah.
Now, you're asking the dental guys to come out and say what we recommend.
Right.
And we're just going to hold off on that.
We're going to talk about that. We'll talk about that because there's people been asking us, well, what implant do you use and why and all this? And I think it's important to choose an implant. Like all implants we know will integrate. That's not the problem. But it's important to choose an implant based upon sound principles of science. And we're going to talk about that at the end. But I think that the first thing to realize is that you can choose, there's lots of implants that will work, but the advantage of this bone level platform switched conical connection implant is it's the most adaptable to multiple situations. Because why? Well, if you have a polished collar implant, for instance, it's limited in certain ways because of the ability to not place that implant subcrestal, which you might want to do if you have thin tissue. If you have a polished collar implant, you're probably going to be doing more soft tissue augmentation if you want to have bone stay. So he goes right into this. He shows a great illustrated summary in figure 10.1 of 3 different clinical situations, with a situation of enough vertical soft tissue thickness, less soft tissue thickness, but more than 12 millimeters of bone height before an anatomical structure is reached that you don't want to hit. And the third is there's less than 3 millimeters tissue and less than 12 millimeters of bone height. And folks, if you've listened to this podcast up through these episodes, you kind of know how we're going to handle those 3 scenarios. If we have more than, greater than, or equal to 3 millimeters of soft tissue, and let's just assume we're using a bone level implant that's does not have a polished collar, of course. Where are we going to place that implant? Well, we can place it at the level of the crest or slightly subcrestal, because we know that that we're not going to be limited by our soft tissue thickness. We can put that implant right where it belongs, and from a result or a standpoint of the bone, and we don't have to drive it any deeper. We don't need to leave it shallow. We can place it according to the protocol that manufacturer subcrestally. If we have less than 3 millimeters of vertical soft tissue, but there's a ton of bone, in other words, you're not...
Yeah, just sink it deeper.
Yeah, then drive it deeper in order to account for that.
But John, you cannot do that with a polished collar, and you cannot do that without certain types of good conical connections.
That's where
it has to be a great connection.
Right. So that's where your implant system starts to matter, Wes, right? I mean, if you have tons of tissue, then it really isn't going to matter what you use. As long as your tissue and bone is adequate, you can pretty much use whatever you want. When you start getting into more limited soft tissue thicknesses and you need to place the implant deeper, assuming you don't want to augment the soft tissue, okay, now you need to have an implant that you can place subcrestally with stability of the connection and also with platform shifting. Why? Not just because it maintains bone, which is great, but also you need to be able to get your parts on and off easily with when you're taking impressions, when you're placing restorations, without impinging on the bone, because you're going to be subcrestal. And if you have,
you better know how to bone profile, John.
yeah,
that's what
that's
you're
right.
saying.
You got to either got to know how to profile bone and have parts that are smaller than the implant width, so that you can just get them on and off. The
right.
third scenario, though.
Yeah, let me just take this one here for just a second, John. I'm going to interrupt you just for a second because I don't think you would really understand why he said 12 millimeters was your limit unless you've done surgery for a while. Because when you start dealing with ridges that you have less than 12 millimeters of bone available, that there's some sort of anatomy there, whether it's the sinus, the inferior alveolar nerve, or just in the lower anterior. I mean, it could be the base of the mandible, if you're doing an all-on-4. So what you're saying here is that there is a massive amount of tissue lost, soft tissue and bone. Now, this is interesting because I'm a believer in short implants, and the particular implant system that I'm using has a short implant with a deep internal conical connection that's platform switched, but I can offset that subcrestively. But the problem that I find in those situations where I'm using shorter implants, the tissue is so deficient, the soft tissue, both vertically and horizontally, that you're going to need some type of augmentation. And this is why John and I think in some of your patients, you need to have the wheelhouse of being able to augment the soft tissue, which is why we put ourselves in front of Pat Allen, the master of this. So I think that's why he has this third scenario, less than 12 millimeters of bone. You need to possibly consider augmenting the soft tissue in some way.
Right. And if you are thoughts, comfortable with shorter implants, you might be able to push that scenario, right? So if you've got, say, 8 millimeters of bone and you have thin soft tissue, maybe if you have a good solid connection implant with platform shifting and you're comfortable, say you got a 6 millimeter long implant, well, maybe you can still drive that 6 millimeter implant a little bit subcrestal, and you can be okay without augmentation, assuming you've measured and you know where you're at. But, that is definitely increasing the complexity. And what I appreciate about Lincoln Vicious here is he's trying to stick with the most time-tested approach here, which is using more of a conventional length implant, thinking about taking everything to the safest point it can be, and as some
4x11s, right? I mean, that's the most used implant of all time, the 4x11.
So he's looking at what can we do to be the most predictable, and certainly short implants. A lot of people look at short implants, go, oh yeah, we got short implants. Well, they're very complex and they're not easy to place, and they're not. They work amazing. But
and you better not get bone loss on those.
Right, but exactly. But you don't have a lot of leeway here. If something goes wrong, then you lose 2 millimeters on a 6 millimeter implant. You just don't have a lot more to give. So I think that this is brings it all home for us that we need to be thinking about this. And then he goes into different scenarios of kind of how. Okay, so if you need to augment, when do you do that? How do you do that? He talks about how you can do that at the time of implant placement in a single stage.
Yeah, he shows a short implant here being placed and how that they augmented it with a, I think it looks like a xenograft of some type.
Yeah, he's a fan of porcine-derived xenograft, which is interesting. So there's two different approaches. You got your mucograft, which is, I think, the most common porcine-derived collagen matrix. And then you got your alloderm, which he used especially earliest studies that he did. And I think it looks like he's moving more. And we need to have him on the show, of course. We need to talk about what are you using, because everybody wants to know that. But it looks like, according to the book, that he's using more of the mucograft material. Which
I think he's using more xenograft materials, which we know that Pat Allen talked about, that he'll be moving to a xenograft material coming into the United States in the next 18 months.
And I think that mucograft is he's liking that more. Again, I'd love to talk to Lincoln Vicious himself and kind of ask him, what are you liking more about that? Is it the handling characteristics? Is it the histology that you're seeing, in other studies? What is it that you're liking more about this versus alloderm? But I think either one can be successful here, and I think he would agree with that as long as you are augmenting. And he shows some techniques about how to do that at time of implant placement. If you are doing a single stage or a 2-stage surgery, you can be successful either way. But you have to be able to understand the surgery there. You got to be able to advance the tissue properly, get primary closure. Not always an easy thing, as we've seen after taking Pat Allen's course. Sometimes it's a lot of advancement of tissue, sometimes a lot of immobilization of tissue. You have to be aware of where you're at. Definitely not an easy, and definitely a time-consuming procedure. And here's an interesting thing. I want to maybe focus on this for just a second. How many specialists do you think know how to augment soft tissue? I mean, I'm talking about around implants, okay? Periodontists, let's give them a lot of credit around teeth. They are masters of soft tissue augmentation. I think most of them are. But why is it? I mean, I don't see this being done very often. Why do you think that is? What's going on out there? Is it a lack of understanding, you think, or is it really more of what I think, the elephant in the room, which is, how do you charge for it? And it takes time.
Yeah. Let's just talk about that for a minute. It's time consuming.
Yeah.
And you can't charge enough for it.
Yeah. Or if you do, all of a sudden people start saying, oh, well, why is that surgeon's implant always however much more?
Because let me just say this, is that this stuff, whether you're using, Mucoderm or Alloderm, or whether you're using xenografts or allografts, right? Unless you're doing autografts, right, you're going to have some type of overhead. Now, if you use an autograft, you say, well, I can use an autograft every time. Well, your patients hate that for one, so the patient comfort factor, and you're not going to have very many patients accept that. And their word gets around that you're hurting the palate.
Right. If you're cutting the palate every single time, I mean, that's fine.
Right.
But,
that's fine, and that works.
But there's a downside to that, of course, too.
There's a downside. And you don't have overhead of that, but you have the time factor.
Yep.
And we know that for single teeth, you need to be booking about an hour and a half for this procedure.
Yep.
And that's from the master. Now, there's some of you that probably could do it faster.
Sure.
Some of you probably do it slower. But the average time is about the time that it takes you to prep a crown and seat a crown.
Yep.
Okay? So that's an hour and a half. Now,
I'll just tell you,
don't think
my oral surgeons that I
I know what he says. He told me. He's like, I don't have time.
Yep. This is the problem. This is a major issue. This is a major issue.
What are we going to be dealing with, John, here in 10, 15 years at the beginning of the end of our career, the last 10 years of our career?
Yeah.
Right? You know what we're going to deal with is all the slop that either we created, right, because we didn't know what we were doing, or other people have created. And so I'm a little concerned about it because we didn't know, okay? We didn't really know.
Right. At the beginning, it was a lack of understanding that creates the problem.
Now, I would say that now there's enough evidence, and you hear us talk about evidence and research. Hands down, let's just sum this surgical portion up right here, okay? The first 10 chapters, hands down, if you do not have adequate soft tissue, you better be grafting.
Right.
Or you better
changing
be altering your
protocol.
surgical technique and changing your protocol.
Right.
Because if you don't, you're in trouble.
Yep.
And it's not 1 year, it's not 2 year, John. To me, it's the 5 and 10 year results.
Yes.
And that's where it becomes a real problem. And you try to fix it at 5 and 10 years, because Pat Allen showed us it is a lot more difficult and the results are unpredictable.
And also, I think the takeaway from this is, if you've been placing implants, if you're just getting started, man, it's awesome, because you can immediately incorporate this into your process from the beginning, and you can basically take this and immediately implement this and start this way.
So good.
But the hardest thing is, if you've been placing implants for a while, you are going to need to be, if you haven't been thinking about this, it's a major re-education. You have to think about your incision design totally differently. You have to think about your implant placement depth totally differently. You have to think about your implant design totally differently. What am I going to actually put on the shelf? You got to ignore basically everything that every company will tell you about whether their implant is better than the other because of some bone loss study they'll show. Because it's almost all BS, man. Because they weren't paying attention to soft tissue thickness. They're cherry picking a study that never looked at soft tissue thickness, never looked at incision design, never looked at really attached tissue. Most of these, they just simply looked at radiographs on year one and at time of placement, and they said, look, the bone looks great. So we have to really
I think let me just say
this.
this is that you're gonna frustrate a lot of people with this knowledge, and you're going to have to walk away from conversations because you will get criticized, and I would just walk away because it's either a lack of understanding of the concepts. It's a lack of understanding of the current and most up-to-date literature, and literature that has been repeated and proven in time, and very excellent research has been done to show that these concepts work.
I'm just gonna say this too, Wes. And you guys, I think, know, you've listened to the show long enough. We don't plug our stuff very often that we're doing.
No, we don't.
But this is what we're teaching people when they come to our courses on implant placement and restoration. We are actually teaching them when they learn how to place their very first implant.
Yep.
We're saying, okay, where is the bone? Where is the soft tissue? If you only have 1 millimeter, what are you going to do? You're going to have to either use a shorter implant and drive it deeper, or you're going to have to augment the tissue. Which is your decision? And what type of implant should you use here? Can you use a polished collar here? What's the advantage or downside of that? So if you've gone to an implant placement course, and you've just been slamming implants, flapless placement, tissue punching, using whatever implant system they have, if they haven't even told you why you're using that system, if they're not teaching you about depth and soft tissue, whatever, that's basically, I'm not going to say it's 20 years old, but it's probably more than, it's 5 to 10 years out of date at this point.
Yeah, it's 10 years out of date, man.
Yeah. So because
10 years out of date.
Linkavicius is publishing this starting off 10 years ago, and now we know that it's an issue. So we need to
we don't plug our stuff very often.
Yeah, I mean, we're trying to modernize.
But John, when I wrote the implant engineering section, the online module for RDI, it goes into why we choose the type of implant we choose for teaching first-time placers, because it has flexibility to tackle 90% of the cases. So listen, if you want to come and you want to learn from us, there are other people to learn from. You're going to hear these concepts being taught. Yep. In fact, if you sign up for our course this year, guess what? You get just this year in 2020. I hate it for those in 2019 and the years past, but this year we are giving all participants of restorative driven implants a copy of Zero Bone Loss Concepts.
Yeah, because it's what our curriculum's it's based on. Yeah, and we're not getting those for free or anything. We're paying not getting those for them. It's not. We have no. That's not agreement.
We appreciate Quintessence,
but Quintessence is good on them to get together with Linkavicius and publish this. And it was so funny when we developed this whole curriculum to teach, and this book wasn't even out yet, but we were aware of his studies.
And you called me,
and I called you, and I got the book, and I was like, Wes, you're not going to believe it. This book pretty much is our curriculum, like the way we're teaching people to place implants, and it's all because we've been trying to keep up with the literature for the last 10 years.
We got a little lucky.
Yeah,
right?
To start.
Right. Yep. We also being read and well researched pays off, John.
It does.
It pays off in a big way. Also, it pays to be very humble. Okay, pays to be very critical of yourself.
Yeah, being willing to accept the change.
Being willing to be wrong and accept change.
Yep.
And so listen, John, this has been another great episode. We've kind of concluded out chapter 10. I'm excited about the prosthetic concepts. Yeah. There'll be a lot of feathers that will be ruffled here, okay? And a lot of things that, John, you and I are going to have fun talking about.
Oh, yeah.
And so, listen, if you're listening to this and you know someone, right, that hasn't heard the Dental Guys, hey, listen, send them a link to our podcast. TheDentalGuys.net is the website. You can find us on Spotify or iTunes. That's Apple Podcasts now. Also, on your favorite podcatcher, John and I use Podcast Addict a lot. We've used that for years. And so we really appreciate those that are following us on Facebook. Check us out there. Also, did you know we have a YouTube channel that's growing?
Yeah.
It seems like we're getting more and more subscribers to that. I think we're over 1,000 subscribers now to our YouTube channel.
And leave us a review, please, on Apple Podcasts. That is how people find us. That's not directly word of mouth. That's hugely beneficial. Leave your review. Tell Apple Podcasts what you think about us, because that is a direct link to getting people to listen to us. We really appreciate everybody that leaves those reviews.
Some of you have expressed interest about me meeting us, we will be available at the Academy of Osseointegration. We don't have a planned meetup yet. And John, I want to kind of talk to you about what that could look like if we could have time. I don't know if we'll have time for a meetup, for maybe coffee in Seattle, which would be epic, a third wave coffee.
That's right.
Like meetup, Dental
out.
Guys listeners. That'd be awesome, right? Yeah. And so, hey, listen, we really appreciate you listening to our show. It's really a privilege to be able to review a book like this. It's high quality. Check it out. If you need to know where to go purchase it, you can go right to Quintessence and buy it from them directly, or you can check it on Amazon and have it shipped to your house in 2 days. And so we appreciate those that have been sending us pictures that they got their book in over Christmas and it was a Christmas gift or something like that. So that's really cool. So for John, I'm Wes, and we are the Dental Guys.